Yes, Dr. Priya.
Yes. Good morning. Thank you, sir, for the introduction. We'll be rapidly going through in the next 15 minutes about the rapidly progressive ILD because as the previous speaker, ma'am had already covered most of the myositis-associated ILD as well. So usually the idiopathic interstitial myopathy, it's a spectrum of disease where it includes the dermatomyositis, polymyositis, and an overlap, and an inclusion body myositis, and an immune-mediated necrotizing myopathy. And the other thing which we commonly see with the RP-ILD is the anti-MDA5 positive amyopathic dermatomyositis, which is clinically they may have some skin findings consistent with the dermatomyositis. However, the muscle involvement may be less predominant in them, and they have an anti-MDA5 positivity, and they are those subset of patients who go for a rapidly progressive ILD. So as ma'am had already gone through, it is so many of these clinically important symptoms which we can pick up in a OPD, and we can predict that these patients can go to a rapidly progressive ILD as mentioned. As mentioned already, anti-MDA5 antibody dermatomyositis, they have more of skin manifestations than the muscle manifestations. So there was an age-old criteria in 1975 by Peter and Boher et al., which is not currently followed, and after which the EULAR and the ACR criteria came for the adult and the juvenile IIM. So here we can see so many other symptoms, but ILD is not included in this criteria. And the serologically also they have included anti-Jo1 here, and it is a bit complex calculation based on this points. They calculate the probability of IAM with biopsy and without biopsy. They have a classification like this. So based on that, if the patient comes under this IAM, there is no definite definition for the RP-ILD. Many studies have shown like there is a rapidly progressive respiratory symptom and lung function over the period of weeks to 6 months. Some guidelines have even told even over a month there is a rapid progression of ILD. However, various studies, they have taken over weeks to 6 months, and it's a radiological and clinical rapidly worsening ILD. And we would have heard about myositis specific and myositis associated antibodies, and this myositis specific antibodies will be positive. It will be more specific for those ILD as mentioned, like as I have circled in this red color. So this anti-Jo1 antibody is specific for anti-synthetase syndrome, and it is very diagnostic, and anti-MDA5 for an RP-ILD. And this myositis associated antibody, they may be coexisting with the other myositis and the other CTD as well. So when these coexisting antibodies are also present and the patient has an ILD, we should always have underlying suspicion whether the patient has a risk factor for going into RP-ILD as well. So this is how it is. Mostly the MDA5 which presents with the ILD more predominant, and the Jo1 and the PL7, PL12, they present more with the muscle predominant, and the dermatological manifestation predominant is the lower one, that is the TIF1 and the SAE, and they are more prone to get malignancy as well. So those subset of patients are more risk of malignancy. So this is how the overall the spectrum of IAM is. So when, as we were discussing, whenever a patient comes with a very breathless, so many other conditions can also be thought of. It is not RP-ILD always. So ARDS, or it may be a drug-induced pneumonitis, or any opportunistic infestations, or many of these myositis patients can present with a spontaneous pneumothorax and a pneumomediastinum also. We have had cases like that. And then with a progressive, very rarely they will be associated with a respiratory muscle weakness. So not all myositis will have a respiratory muscle weakness. And sometimes aspiration pneumonia and cardiac dysfunction, pleural effusion, because of the involvement of the other like myocardium, all those also can present with a different acute dyspnea in a setting where RP-ILD is a differential as well. So we'll go with a case-based approach. We have a 38-year-old housewife with a progressive breathlessness over 2 months and with the roughness of skin on the lateral aspect of the palm and the second finger. And as already discussed, mechanics hands and is a very commonly seen manifestation. And any patient with a mechanics hand, such similar presentation, we should always, though ANA comes negative, we should always screen for myositis, and always RP-ILD should be at the back of our mind to predict at any time. they can progress in. So as this patient also came to us with the baseline investigation was initially normal, ANA and RF was negative. She wasn't able to perform a baseline spirometry and she had a significant desaturation in the walk test. Her echo did not show any pulmonary hypertension, and then because of this skin manifestations, when we screened, she was positive for anti-MDF5 and PL7 was also. PL7 is one of those antibodies which is specific for myositis, specific antibodies which came also positive in her. So initially her X-ray was showing some reticular opacities and minimal ILD changes were there. And then this was her initial CT where we can see there are patchy opacities. I'll show the magnified view of the CT as well. This is on November 11th, and that time the patient was pretty stable and she was discharged on immunosuppressants. And after which she came here with, in November 24th, she presented with a rapidly worsening symptoms of breathlessness, and and her oxygen requirement was also going on high, and this was her second CT at the second time of admission. We can see that there are worsening infiltrates bilaterally with the increase in the opacities on both the sides. Like bilaterally, symmetrically, there are worsening infiltrates are seen. So I had compared both the CTs as well, compared to the 11th November, which was an outside image she had come with, and compared to that our 24th November CT also, we can see more prominent and there are more new areas of involvement as well there, seen in the left lower lobe all. So this is another cut where we can see there is a new areas of involvements are seen within this short duration of this symptoms. So after that she went on worsening hypoxemia and she had to be shifted to ICU with worsening breathlessness, and we can see the serial X-rays being worsening, and finally we can see she got intubated also with worsening hypoxemia, and this was her final X-ray just before she succumbed. So in the course in this ICU, initially she did not have fever. However, after there was a progressive breathlessness. After that, she developed fever also, and with but however, her serum procalcitonin levels were low, and the CRP was rising from initially it was 4, and then it became 19, and there was a worsening hypoxemia, and initially she was pulsed with steroids for 3 days, and still there was worsening hypoxemia requiring ventilation, and ET aspirates showed infection also, showed isolates of Pseudomonas aeruginosa, and then she was given 3 days of IVIG also, but then she still succumbed. So this is how we could see a rapidly progressive ILD with an MDA5 positivity. So as sir had mentioned, in many Japanese data, they have shown that majority of the patients, like 65% of this IAM group had ILD, and most of them had ILD at presentation itself, as we saw in this patient, and most of these patients had a rapidly, like 38% of the patients had a rapidly progressive ILD, and the remaining patients had a chronic, slow, non-progressive ILD, and the most common HRCT pattern was NSIP pattern. So this was also data from there. And many studies, if we go through, they have given so many risk factors which could predict the progression of and the mortality also in RP-ILD. And the commonest thing is the MDA5 positivity. And if there is a ratio between decreased lymphocytic neutrophilic ratio and elevated CRP, skin ulceration was associated with a high mortality. And high ferritin levels, many studies have shown more than 1,500 had a high mortality. And BAL, if at all done, it had showed a low lymphocytic predominant BAL. And then serum LDH and prognostic nutritional index based on the albumin levels and the lymphocytic ratio was calculated, which also showed a high risk of mortality in many of these studies. And anti-Rho5 positivity is another important antibody, which when coexists with this anti-MDA5 receptor antibody, it also has a high risk, and male sex predominance had a high chance of RP-ILD, and a very rapid progression within less than 3 months also has a risk factor for high mortality. So we'll shortly see the management also. Ma'am had already given an algorithm already. So many studies in RP-ILD have discussed over whether the triple therapy or a double therapy upfront is important, because it's just rapidly progressive ILD. In another few weeks, sometimes the patient will succumb to death. So so before going into what drug is the best, it is important to understand the pathogenesis behind this RP-ILD, so that we know where to target and what to target. target. So most of the time it is a viral, some unknown viral or a genetic triggered anti-MD5 gets activated, and after the trigger there is both the T cell and the B cell immune mediated responses activates and the cytokines are released, and so it is, we have to target both the T cell mediated immunity and the B cell mediated immunity. And another thing is the interferon 1 production also happens. So the interferon 1 production is usually associated with mainly with the JAK kinase pathway, and that is why the JAK1 inhibitor also is important in the like tofacitinib is also useful in this anti-MDF5 RPILD. So combination therapy was found to be always better. So always many studies have shown upfront combination therapy with steroid for 3 days followed by rituximab and tofacitinib had been found to be successful in many studies. And the ACR guidelines had come up with this rapidly progressive ILD. If at all there is initially, as we saw in that patient also, the IV pulse steroids is very important, followed by 1 or 2 additional therapies have been given. So there also, if there is a severe disease, they suggest upfront 2 additional therapies along with steroid. 2 of these, either rituximab or cyclophosphamide, or if infection is suspected, IVIG and mycophenolate, and other lower drugs have also been calcineurin inhibitors and JAK1. So this all these have been suggested together because to combat both the T cell and the B cell immune mediated response in this group. So there has been, when I checked through that, apart from this immunosuppression, lung transplantation has also been, there is one series of lung transplant in RPILD also, because these patients just worsen within few days and they die. So even when the immunosuppressants are not working, they have, this series had some 4 patients of lung transplant, out of which 3 had survived and 1 succumbed. The 3rd patient had succumbed and the other 3 patients survived. So these patients were on ECMO initially, and then they went to transplant, and here also they had used multiple immunosuppressants, like along with steroid they had given MMF and pulse, and IVIG was also given because infection was also another consideration, and rituximab has also been used in these patients. So to conclude, so anti-MDF5 antibody is the very important, is positive, then we should always think of this RPILD in our mind when we see patients, especially these distinct cutaneous lesions are very important. When we sit in an OPD to see these small things can give us a clue so that we test myositis profile in these patients, and not much of muscle involvement is usually seen in these patients, and ILD is seen in about 60% of the patients, like in sir had told, in Indian data it is lesser. However, in Western and Japanese data, it is higher, and 40% of them has a propensity to develop an RPILD, and anti-MDA5 patients with RPILD are generally resistant to both steroids, so they may need upfront dual or a triple immunosuppressive therapy, and even when the ILD, overall the mortality is also higher when compared to the other CTD ILD in anti-MDA5 associated ILD. Thank you.
Thanks, Dr. Priya, for being on time and for the comprehensive. Any questions from the audience? Yes.
This rapidly progressive ILD, post-transplant, we see a lot of, almost 50% of them have incidence of tuberculosis. So out of which, in that 50%, both of them were on ECMO, and one had a tubercular empyema and one had a post-transplant, around 2 months, had a lesion that was turned to be tuberculosis. So probably because of higher immunosuppression pre-transplant and after the immunosuppression after transplant, we are seeing almost 50% of them having incidence of tuberculosis post-transplant, especially those who are on ECMO as a bridge for transplant. So just wanted to highlight that point about that.
Yes.
Any
comment on that? Or?
Yes, when I went through many of these Japanese data, they have written this infection is another risk, and that's why they used more of IVIG also initially. They had mentioned like that. In Indian data, I have not come across this word actually.
Actually, maybe I just give a quick experience actually. We had CMC, we started doing anti-MDF5 in 2019. So first patient with dermatomyositis with extensive skin lesions, which was not behaving typically as somebody would. So we got it done from Jipmer actually. And that patient was anti-MDF5 positive. So that patient got an opinion from several doctors all over. And all of them wrote to me saying, you have to be very aggressive in this patient. You have to give cyclophosphamide, rituximab and high-dose steroids for this patient. And this patient was a local from Vellore, so they could access us anytime. And her lung disease was not as bad as, she was, I was seeing her over maybe 4 to 6 weeks, and she was quite stable. So I just thought probably I wouldn't go for that much of immunosuppression because the risk of infection and complications for infection is very high. And now, 7 years down the line, she has stable lung disease, not a problem. We just treated her with mycophenolate steroid with close monitoring. And once when she had a myositis flare, we had to give her rituximab. We just give 2 doses of rituximab, and she's off steroids and continuing on MMF maintenance. So the message is basically, just because MDF5 is positive, we don't have to be too aggressive for all MDF5 lung disease. And as I mentioned before, only 2 of our 29 patients had RP-ILD. So of rest of the probably 17 patients, we just need to manage like any other ILD. But only thing is they need close follow-up so that you know how they are progressing. The problem, as you said, is all this immunosuppression is all sorts of infection with high mortality. It's not like infection and you treat them and they come out of it. Many of them die because of the infection and infection-related complications. So, yeah.
Is there a referral bias in terms of which specialty they go to? Because the more aggressive ones may be coming to pulmonologists and less aggressive lung-wise may be coming to rheumatologists, and the experience can be quite different. And just a thought.
Yeah, I was also about to say that they come to us with pulmonary manifestations. So we can't afford to say they won't do well. We also see myositis patients with pulmonary manifestations who don't do so well. So probably we have to leave it at we are still learning. We just have to wait and see how they manifest.
We have to combine
Yes.
information from both the specialties to see where the combined data is.
So basically, probably it should be individualized rather than broad.
Yes.
It's individualized based on each patient basis. I think we are off time. Thanks, Dr. Priya, for that nice, stimulating talk. And for the last session, we
one
have
comment, with your permission. Just take a quick comment because there was a point about